And I did want everyone to know that we do record these. So for those people who missed them, they can see them later on. So I am recording the meeting. And all right. A few more people in here. And why don't we just go ahead and get started and people can catch up if they miss anything. That makes sense. All right, so I'm Gene Ransom. I'm the volunteer chair of the EQIP subgroup, which feels like it's been going on forever. But anyway, we're continuing to try to move forward and get this thing done. And for those of you who don't know who I am, I'm the CEO of MedChi, the Maryland State Medical Society. Now, I know it's been a while since we last met. Well, I guess that's been that long, but it might have been last year, but I'm not sure about that. But it's been a while, like I said. So I thought it'd be useful just to give a little background as to where we were and how we got where we are. If everyone recalls, originally when we started doing this, the game plan was to have a new application, the CMMI, to create an advanced payment model for specialists. Maryland has a really successful advanced payment model for primary care, adult primary care doctors, and the Maryland Primary Care Program. And the state's done a really good job under this new waiver agreement, aligning those primary care doctors with the model. But one of the problems we've had is that specialists do not have a program. And not only do they not have a program in Maryland, some of the national programs can't be run here. So the solution that the HSCRC has been working on is creating an opportunity for specialists to take advantage of programs like those under this new episode quality improvement program. You want to go to the next slide, Maddie? Essentially, we did, though, discover from CMMI that doing a new waiver probably wasn't the best way to go last year for various reasons. And what we decided we were going to do, and the track we've been working on the last few meetings, is fitting this EQIP program under the current model. And for those of you who don't recall, again, the goal here is to start this voluntary episodic payment program for specialists starting in 2022 with the 4 tenets here on the first side: physician ownership for performance, upside risk only with dissavings accountability, having an advanced payment model, which is a really big deal for my physicians because they get a bump in their Medicare payments for that, for those of you who don't understand that, and trying to align with other payer episode programs that are being created. So that's kind of where we are and what we're doing. So today, I'm really excited because first, we're going to have Tequila give us kind of an overview of how things have been going with the work, the great work that all the HSCRC staff has been doing, and go through the timeline. And then we're going to hear from Change Healthcare. And as we've talked about in prior meetings, Change is the new owner controller of the Prometheus Episode Grouper. And hopefully we can have some discussion around that tool and start to maybe think of some ideas on different programs that we'll be able to utilize starting January 1st of 2022. So I think I've already talked more than I was allowed to, so I'm going to stop now and turn it over to Tequila and let her take the reins.
Thanks, Gene. No, I appreciate that. And good morning, everyone. Welcome to today's meeting. For those of you who don't know me, my name is Tequila Terry, and I am the sort of fairly new appointee as director of the HSCRC Center for Payment Reform and Provider Alignment. And so I'm really delighted to be here today just to sort of open up the meeting and again, emphasize the HSCRC's enthusiasm for wanting to create this opportunity to work with specialists on this new EQIP program. So as Gene said, we were really deliberate about wanting to design something that was physician focused. And so that has been the impetus, and really the main goal of this program is to create a physician focused program that enables you all to really be a part of the value-based strategy that we have had as a state. And so as Gene alluded to, the foundation of our EQIP strategy is built on the Prometheus Episode Grouper, which gives us flexibility to have a great deal of data and information on a variety of different episodes that will fit into the framework that we're designing under EQIP. And so today, I want to also, sort of introduce you to the other folks on our team, Madeline Jackson-Fowle, Maddie, who you will hear from shortly, who is our Chief of Payment Reform. And so she'll give an overview of sort of what we've been working on. And then we also have on the line Will Daniel, who's our Deputy Director of Payment Reform. He'll be on hand to help answer questions. And then we have the team from Change Healthcare who will walk through some details about Prometheus. This is our first opportunity really to share with you some of the detailed thinking around how the episodes will work. So we're really excited to share this information with you today and actually get some feedback and discussion. And so with that being said, our initial focus, as you see on the screen, is going to be on gastroenterology, orthopedics, cardiology, but we also are thinking beyond year one to other opportunities that exist in ED and other areas that we've been talking to you all about. So today is really sort of the first conversation about the specifics of the episodes, but just know that the discussion doesn't end here and there will be more to come. And so welcome the opportunity to be here and look forward to having a robust discussion today. And with that being said, Maddie, if you can go to the next slide. So just a quick update on the timeline. So as I mentioned, the HSCRC staff are going to continue to work on key policy decisions related to the EQIP program. And so what you should be on the lookout for is additional meetings and phone calls and outreach and information that we're going to be pushing out as we develop the policy program around EQIP. And the implementation and rollout strategy. We're getting very close to the launch period. So really want to make sure that we're being very communicative. And then we want to highlight a couple of key dates that interested physicians should be aware of. Number one, starting in July of this year, we are going to start recruitment. So actually opening up the opportunity for physicians to actually enroll and participate in the program. We work very closely, as Jean alluded to, with the CMS team. And so they will begin the process of doing the vetting and contracting episode selection process in August. And then September is really where we see the deadline for physician participation that will start in January of next year. And as we've alluded to, January of 2022 is when this EQIP program actually starts. So this is sort of the key dates. These are the key dates that we want to make sure everyone is aware of at this point. And as we continue to move forward to that July timeframe, we're going to continue to keep you updated. If we hear any additional information from CMS and the, during the implementation process, we'll use this forum as a way to communicate that information and let you know if anything changes. But as of today, these are the key dates. And so please keep this in mind. And I think this slide deck, if it hasn't already been sent out, will be made available to everyone so that you'll have this information for your reference. So let me just stop there. See if there are any questions on the timeline. And if not, I think we just want to jump right into the main content for today. Okay. Well, Maddie, I'm going to turn it over to you next.
Thanks, Tequila. So before we turn it over to Change to kind of walk through the Prometheus Episode Grouper and some of their experiences rolling this out with other companies and partners, we wanted to kind of level set what would be dictated by HSCRC and CMS policy and what is really dictated by the Prometheus Episode Grouper. We've talked about a lot of these topics with this group before, and I think, some of these policy decisions are still ongoing. But for the most part today, we're going to focus on the right-hand side of this slide, which is really the episode definitions and how those work with the triggers and how those are defined. Episode attribution and how the Prometheus Episode Grouper kind of layers their episodes and how physicians are attributed the episodes. related cost methodology, or the costs that are ultimately included in each episode, and then performance calculation and some, more experience-based data from the Change Healthcare team. So all of this right side of the slide is kind of dictated by the Prometheus Episode Grouper. On the HSCRC and CMS policy side, we want to be dictating the shared savings and incentive payment calculations, the target price methodology and how that works in with Maryland costs and hospital TRs, risk adjustment on each episode, the quality measures that will be used to both determine AAPM status, but then also ultimately adjust incentive payments for quality performance on the episodes. The reporting and monitoring, which we do intend to push through CRISP, a really streamlined process for care partners who would like to engage in the process in the program. The participation
on the Change Healthcare team.
The participation specialty areas, which Tequila outlined on the last slide, being in the Gastroenterology, Orthopedics, and Cardiology specialty areas, and then CMS policies. So that, I think is a big catch-all, but includes things like QP status, how and when we can set up participation timelines in the program, those types of things. So any questions on the left-hand side, we're happy to answer ad hoc, though today we'd really like to focus on the Prometheus Episode Grouper and more questions on, to that effect. So without further ado, I'll stop sharing and turn it over to the Change team. But please let us know if you have any questions after this, or there's a Q&A section at the end that we're happy to jump in and help out on. So.
Thank you. This is Liz Sheehan from the Change Healthcare screen. So I'm just going to grab the presentation here.
You should be able to share your screen, Liz.
That's what I'm hopefully trying to do here. One sec.
We need like a musical
It
interlude.
wouldn't be 2021 without technical difficulties. All right, so.
Liz, do you want me to share it? I've got a lot of the slides anyways.
I think, let me give it this one last try. Otherwise, yes, Andre. Well, yes, do you mind? It might just be easier.
Okay, and I say that, but there it is.
So let me test my audio. It's been going.
And John, it is going in and out. But Andre, we can see your screen.
Okay, great. All right, well, why don't I just go ahead and take it then, John? If you're having trouble with audio, I can present some of that. Let us know if you get in there, just to make sure we're making best use of everyone's time.
Yeah, great. So can you hear me?
Oh, we can hear you now. That's good.
Yeah, great. Okay. I love the new world. Okay, so good morning, guys. Let me introduce myself real quickly. John Hutchinson. I'm a senior sales exec with all things value-based payments at Change Healthcare. We really appreciate the opportunity to spend some time with you guys this morning. We've worked very closely with the HSCRC team and Care First on building out our presentation. I've got to give some kudos to your group there. We work with a lot of folks on the state level. I've been genuinely impressed with the level of expertise and questions and preparation for our meeting. So thank you, Maddie and company, for that. We've included a Q&A session at the end of our presentation, but please feel free to ask questions at any time. Let me first introduce our team really quickly, and then we'll get to the body of the presentation. So Andre, you want to introduce yourself?
Oh, sure. Yeah. Andre Gonzalez. I'm a physician. I'm AVP of value-based payments with Change Healthcare. I've been working with the Prometheus methodology for close to 10 years. Been working in value-based care and the transition from fee-for-service to value-based care with Change Healthcare, previously McKesson, for about that same amount of time. Prior to that, I've been involved in product management of both healthcare IT solutions with acute care EMRs, and then also a number of medical devices. Holly?
Hi, good morning. Holly Stalker. I am the Director of Client Services. My team is responsible for the implementations and long-term support of the HealthQX platform. For this particular initiative, I am working with Madeline and Shri from Care First to get things kick-started and to learn more about the process and the interaction so we can have a successful implementation. Liz?
Good morning, everyone. I'm Liz Sheehan. I'm a member of the value team here at Change Healthcare. My role is more from a strategic business development as it relates specifically to value-based payments, and I work with both current and prospective customers of ours, helping them to leverage and optimize their value-based payments program. Nice to meet you all.
Thank you, Liz. So next slide, please. So guys, let me give you just a quick download on Change Healthcare, our position in the market from a credibility standpoint and experience standpoint. We have a very large client base really across all lines of business, including Medicaid, Medicare, commercial programs. Note that we are actively working with very similar projects with two states, Departments of Health in Colorado and New York State. We run a significant amount of claims through our analytics engine every quarter, approaching 75 million members, 750 billion in claims, 225 million episodes of care, and just a little bit about some of the savings that we've delivered. So let me turn it over to Dr. Gonzalez. Once again, please jump in, ask any questions, and Andre, if you can go ahead and take us through the deck.
Okay, yeah, thank you, John.
Thank you.
So what we're really looking at here with Prometheus, and I don't want to spend a lot of time here. I think this group has a great handle on why we're doing this. But the key here is the coverage of Prometheus as an episodic care analytics solution and methodology that really allows you to not just look at what's happening in a specific episode, but also to look across a pretty significant amount of services and clinical conditions that really start to help you understand how to better manage a patient and a population. But it does so in a way that is specific enough that you can get to very specific opportunities for improvement, both in terms of quality and outcomes, and also in terms of cost improvement and utilization improvement. So the Prometheus methodology covers anywhere from 60 to 70% of kind of a typical commercial health plan's medical spend. In some cases, it can be more than that. It's usually not less, but there are 97 episodes of care. They cover, procedures and a number of other conditions. We'll get to those in a minute here. But the key here is just that there is a significant amount of medical spend and clinical kind of analysis that can be done to look at where there are opportunities for improvement. And I think that's the key. And I'm sure, a lot of you have been involved with episodic care programs before. One of the things that is unique, I think, about Prometheus is just the span of the episodes, and still the ability to get to very specific budgets and be able to actually reconcile bundle payments, and going there. So it's a pretty, broad view of medical care. Change Healthcare just last year acquired Prometheus Analytics. We had been using this solution, as I said, the methodology for about the last 10 years through various solutions that we had taken to market. About 5 years ago, we acquired a company called HealthQX, which is a very specific, episodic care analytics platform that really covers the majority of what you saw in that previous slide that John showed in terms of our customer base. But what we found was that the methodology really required more investment to continue to expand it. Right now it covers, like I said, about 70% of medical spend. It's used in thousands of contracts, actual episodic care bundle payment contracts across the country, not just by, our customers, but by, other vendor partners who are continuing to have access to, to that methodology. And really, we have decided to focus on this as a standard that we don't want to just use for, Change Healthcare, but to also make available or continue to make available to the industry as it has been. We recently hired a physician, a CMO, Dr. Summer Paul Callon. We built up a clinical coding team, both to maintain the content, because, as you know, codes change, CPT, ICD codes, the NDC codes, the drug codes, they all change over time. So it's important to keep those up to date. We've also started to create an advisory council that will be charged, or that is charged, with really expanding the methodology and reviewing the content that's there on a regular basis to make sure that it stays up to date. I believe somebody might be, if you're not speaking, maybe if you could go on mute, I just hear some background noise. Thanks. So the Prometheus methodology was launched in 2006 with support from the Robert Wood Johnson Foundation. It was maintained initially by HCI3 and then moved over to another organization, or they merged with another organization called Altarum. And that's really where we've been partnering for some time with HCI3 and Altarum, and just recently decided to acquire the methodology directly. The model is focused on these 97 episodes of care that really are looking at the care that, from an evidence-based perspective, is expected to be delivered for an episode. And one of the key aspects of this methodology is the idea of potentially avoidable complications. So it's fairly straightforward to say, okay, what are the services that should be included in, say, a colonoscopy, or a CABG, or an angioplasty? But then really where you start to get, I think, some of the unique alignment in terms of the Prometheus methodology is when you start to look at what are those potentially avoidable complications that represent a very negative outcome and a very negative experience for the patient, but also represent significant costs for whoever has to pay for that care. So by aligning the goal of avoiding those complications and controlling costs, you really start to get that I think, alignment of cost and quality. So you're not just improving costs by cutting the number of services that you deliver, because if you're on the hook, if you're responsible and accountable for any complications that occur for the patients who are in those episodes, then that's actually going to represent not just a negative quality measure or negative outcome experience, but it's also going to represent significant costs. So by doing the more preventative care and ensuring that care is coordinated across the continuum, instead of just delivered by a surgeon or by a physical therapist, really coordinated across all of the providers in an episode, that's really where we've seen our customers and their provider partners benefit significantly and really start to generate some of the savings that John showed there, real savings in these programs. Those episodes, as I said, they cover medical claims, they can cover pharmacy claims. It really depends on what is available. It's very important to have all of the claims across the continuum of care, because if you're missing something like maybe skilled nursing facility claims, that can represent a significant cost that is kind of hidden if you don't have that. So when we work with our clients, one of the things that we find is a lot of times, even a payer might think that they have all the data in a data set, but we find that there are missing claims, and we can see that because we kind of know what those episode costs should be. We know what the utilization should look like, and when we start to see gaps, we can start to identify where those gaps are. And then once you have that solid view, tracking that over time is really where you start to see kind of some of the unwarranted variation, and then you can start to deliver that information to providers so that they can really address that. We'll get into a little bit of the leveling. This is another part of Prometheus I think is very significant, is that when you look at something like a knee replacement, it's important to understand, for the 90 days post, post surgery on the knee replacement, what was the experience of the patient, what were the outcomes. But then it's also important to be able to look at a higher level and see, say, osteoarthritis, and see how a particular provider or practice is really managing all of their patients with osteoarthritis, to understand how frequently their patients are getting knee replacement, what are some of the other, maybe more conservative therapies that are being used, and start to compare not just the procedures, but really understand how the chronic conditions associated to those procedures are being managed. And the example here would be, for instance, like CABG or angioplasty going up to coronary artery disease. So this is a very high-level view of how the Prometheus services, or the Prometheus methodology, assigns services. So you start off with the total cost of care, as I said, to really make sure that you're looking at a full view of what's happening for a population. It's very important to understand things like member eligibility. If a member loses their eligibility halfway through a 90-day episode, well, that episode's probably not valid, right? Because you're missing a significant amount of the services. So, you might want to filter that out. Understanding provider files and being able to understand attribution is very important. We go through and we assign all the episodes. So basically trigger all the episodes, identify all the episodes that exist in the population, and then go through and service assign all of the different claim lines to those episodes that are relevant. Within those service assigned claim lines, you have basically typical care and then potentially avoidable complications. We've already talked about the potentially avoidable complications. Within the typical care model, you have the idea of core services and potentially avoidable services. So that's where you're really looking at some of those overuse services that would align with, like, choosing wisely, to understand not just, these aren't services that represent complications, but they might represent excessive use. The main focus of the clients we work with is really on, typical care and potentially avoidable complications. But I just think it's important to point out that that those aspects are there. There is a severity adjustment or risk adjustment model in Prometheus. It's a little bit different than a lot of the kind of more population-based risk adjustment models, or kind of more broader-based risk adjustment models. The Prometheus methodology does a risk adjustment or severity adjustment for each member in each episode. And the reason for that is that a patient, say in a knee replacement episode, might have different comorbidities that would be relevant than, if they're, having a colonoscopy or a CABG. A lot of the comorbidities will be similar, but the impact on those episodes and the way that those comorbidities manifest into what is ultimately an expected cost for the episode can be different. So that's the nature of the risk adjustment or severity adjustment. I'd say about half of our clients use severity adjustment. A number of our clients decide that they just want to use kind of a historical case mix for their provider partners. These are all kind of choices, and I want to make sure to clarify that when I'm talking about this, I'm kind of talking about the methodology and the way it can be used. And as I get into some of these reports downstream, again, these are samples, but for your program, your leadership and the folks who are really leading the charge here, we'll be working with you to make a lot of these decisions. So I just want to make sure that it's clear that this is an overview of the methodology, and they're, the project team, the program team will be providing the specific guidance on, what your program is actually going to look like. So there are four basic categories of episodes. The first is chronic, so that would be care for conditions like diabetes or heart failure, coronary artery disease, osteoarthritis. You have acute medical episodes. Those would be situations like strokes, pneumonia, heart attack. You have procedural episodes, which would be, like the classic kind of joint replacement, colonoscopy, cabbage, and then other conditions. Other conditions would be care for things like pregnancy and cancer episodes that just don't quite fit into any of those other categories, but are important episodes and clinical care to address. In addition, there's a more generic episode type called system-related failures. These are more focused on what you could consider kind of never events, like sepsis, falls, things like that. If these events occur, or if a patient experiences these, basically complications during an episode, they will actually be included in the episode as a potentially avoidable complication. They are created as a separate episode if they occur outside of the duration of another episode. This slide kind of gives an overview of kind of how episodes are structured and how they're created. So one of the things about episodes of care, I think, is that they can definitely be used by primary care, like I said, to understand kind of how primary care providers and practices are coordinating care and managing care for chronic conditions, and even for some of the specific episodes. But we all know that patients have to be referred. It's not like primary care can deal with everything that needs to be done for a patient. And episodes are a great way to engage specialists that might not be as engaged in an ACO or a patient-centered medical home. So it's a way to really provide those specialists with relevant data for the episodes that they're accountable for, and give them the level of detail that they can see, how their practice compares to other similar practices, that are also in that analysis. And then for them to see specifically within their own practice where they might have unwarranted variability in care, unwarranted variability in costs, so they can start to identify procedural and sort of process changes that they can implement to improve the care that they provide to their patients, and do so at a better overall cost. So the way that that's done is that episodes are triggered. They're usually triggered by a procedure or a diagnosis. So it would be a procedure typically with a procedural episode, or a diagnosis with like an acute care episode or a chronic condition. Then the episode typically has a look back period and a look forward period. Both of those periods are configurable. The key is that you want to set the goals for your episode, and that's very important. The Prometheus episodes are created, I think, with the goal of being as comprehensive as possible. But certainly there are specific programs and goals that can lead to tweaking, and there are configurations available within the methodology. That as we get into more detail, we can kind of expose those. But I think most of the clients we work with use the standard configuration. There's definitely some goals there, or some benefits there, in terms of being able to kind of have a standard and consistent view of what's happening in an episode of care over time across different populations, so that you can actually start to compare apples to apples. That's a very important part of identifying those opportunities for improvement in cost savings, quality improvement, and then really in helping ACOs and medical homes understand, how the specialists that they're referring to are performing, and be able to communicate with those specialists to say, okay, here are the things that are working, here are the things that are not working, and come with data, right? Really come with data that can be useful for that work. What we found is initially our clients were very focused on bundled payment programs and contracts. and they still are. A lot of those programs are expanding, continue to expand, and we continue to work with new clients who are, really wanting to automate and scale up their programs. But what we've also seen over the last few years in a much larger kind of use case that, that our customers are supporting is to support their population health programs, their ACOs and medical homes, and just provide this data, even if they're not, in a contract for, with a specialist for a specific episode of care and a bundled payment, to give the specialist the data to understand how they're performing relative to their, to their peers and in the local community. It can be very helpful for those ACOs and medical homes to decide which specialists they're going to refer to, and then also, like I said, to to work with those specialists to improve coordination of care. So this is a diagram, of a basic diagram of how episode associations or leveling work. And what you see here is different levels of the Prometheus methodology. The reason that there are different levels is to kind of account for the different behaviors and characteristics of the different episodes that I went through, the procedural, acute, chronic episodes. The way the model works is every episode is created as a standalone episode at level 1. And at level 1, you're able to really see everything that's happening and all the services that are assigned. And that can be a very useful level to understand. But then to really understand the complete view of an episode of care, you need to go to its level of completion. At level 2, that's where you have association of procedures or episodes that might be related to each other. Like in this case, you see a PCI or an angioplasty rolling up to a CABG. Well, that's kind of can be part of standard planned care for that CABG to have a follow-up PCI. So even though that PCI is its own episode, and we want to be able to understand what's happening in that angioplasty episode on its own, it's also important to understand how that relates to the CABG that was really the initiator, if you will, for that angioplasty. Level 3 is the first completion level. So that's where all procedural episodes complete. So that would be like a CABG or a knee replacement. What you see happening here is you see this AMI or heart attack and angioplasty rolling up to the knee replacement at level 3. What's happening there is that the patient who had the knee replacement had a heart attack within the look forward period, say the 90 days of period of time after the actual knee replacement procedure. That heart attack needs to be captured as an episode. We need to understand how the providers who are accountable for that episode are performing and what's included there. But we also need to acknowledge that if that patient had a heart attack 3 or 4 days after their knee replacement, well, it was probably related to their surgery. And it was either, the fact that the patient, had an increased chance of clotting, and that clotting risk wasn't really managed very well after the procedure, or maybe the patient wasn't a great candidate for surgery and anesthesia in the first place, and just their cardiovascular health was not sufficient for a knee replacement. In any event, it's important to understand that occurred during the knee replacement, and that's the reason for associating it to that knee replacement, so that you can see the full view of what occurred with that knee replacement, including the fact that the patient had a heart attack. And I think the important part of this is that the information is all there, right? So if you want to look at the heart attack on its own and kind of understand how the cardiologist who managed that heart attack performed, then you can start to see that, how the hospital managed it. But then you also see that this occurred during the knee replacement episode or shortly thereafter, and was probably associated with that surgery. Then you can also see level 4. We have the AMI here, so you can see that the CABG related to that AMI would associate to the heart attack, and you see that is associated there. And then you see the heart attack associating to coronary artery disease and diabetes. So you see there that the chronic and acute and procedural episodes can actually associate to chronic episodes. In this case, this diagram doesn't have osteoarthritis, but that's another example of chronic episode that knee replacement would actually associate to, in this model. And then of course you can look at all typical costs, all complication costs. There are a number of ways to kind of parse this data and really start to look at it and understand how these episodes are occurring, how the healthcare community that you're working with and both the facilities and providers are managing them. One thing that's also nice about the Prometheus methodology is that there isn't just a single attribution. So there are multiple attribution methods, and all of them will apply wherever they can. So in the case of a procedure like a knee replacement, we have a facility, so there'd be a facility attribution, and there would also be a professional attribution, so the surgeon who actually did the knee replacement. In the case of a chronic episode, there are multiple attributions. You can look at attributions like E&M services, look at the volume of services. Whoever had the most services for a particular patient in an episode would get the attribution. You can also look at the cost and add up the full cost. So it's just different ways, and both of those attributions will be there in the methodology. So as you're looking at these episodes and really figuring out how to assign episodes, you have flexibility and choices. Certainly when you get to the point of a contract, you want to kind of nail down those choices and make sure that you've got a very consistent and well understood model for doing it. But in the initial phase, there is this flexibility to be able to make these choices. Here I've listed not the full 97 episodes, but kind of the main episodes that we typically see our payer clients work with. We've highlighted in yellow, these are kind of the episodes that we see as currently live in the market and have a high interest and a lot more contracts around those episodes. And then I've also highlighted in purple the episodes that the EQIP team is looking at. I think there have been some changes since we made this slide, or we've gotten some updates. So again, any details and focus on these episodes will be communicated by your team. But we do understand that you're looking at ortho and cardiology and GI as kind of your main clinical categories of episodes. Those are certainly, as you can see, well represented here and episodes that have gone through a lot of pressure testing. That's one of the things I want to emphasize about Prometheus. It's because it's been around for so long. I mean, it's been around for close to 15 years now, and literally has thousands and thousands of contracts out there. A lot of providers have seen their patients come through in these analyses, in their shared savings reports, their shared risk reports, and that has led to a refinement of these episodes. This is not a done and etched in stone sort of methodology. If there are complications that are showing up that just aren't relevant, those can be addressed. If there are new procedures or that need to be included in an episode, and a provider saying, look, you're missing out on these things, then we address those. So that's part of the reason why we acquired the methodology, to make sure that we could be very responsive. As a company, we've got a lot of history in terms of content development, especially working with Interqual and our claims extend, claims editing solutions. So we're leveraging a lot of that expertise that we have to hopefully continue to improve and build on the great work that has already been done by HCI3 and Altarm in this space. Okay, now I'm going to go through just a series of sample reports just to show you the kind of data that the model can pull out. Again, the reports for this program and for what you're doing are going to be different. We know that, but it's kind of hard to show this data without showing some reports, and so these are reports that we've created over time with our clients. What you're seeing here is a total cost of care analysis where you can see kind of the cost by episode category in the upper left there. If you hover over kind of those different colors, you'll see some are chronic, procedural, acute care. You can see like the total cost breakdown across the top with typical, potentially avoidable complications. And then over to the right there, you can see all of the different specific episodes that have been created in this population, with the average cost, the total cost, the number of members, and then you can obviously drill in to all this data. And because we're assigning at the claim line level, really any analysis like this, when you're looking at the episodes and the providers who attributed to those episodes, you can always drill down to that claim line level and really start to show then the providers, okay, here are the services that went into these episodes, and show them, you know, kind of where some of that variability exists. In this case, you can see the call out here, the purple call out. You see the practice 813, 824. Those are obviously just placeholder names. We can't identify any real client data through a demonstration like this. This is all test data that we use internally that's been totally de-identified. But you can see that then you can get to the number of episodes that practice is accountable for, and the average cost, and then you can drill down further to get to the very specific claim lines that are involved there. You can do analyses like looking at the bottom left there, the total member claim expense, the age. There are a number of different ways this data can be organized and visualized to to support your needs in your program. We know that colonoscopy is of interest to the program. This is a sample colonoscopy report. Again, I don't want to represent that this is exactly what you're going to have, or even that it would look anything like this, but this is one way to look at colonoscopy. In this case, what you're looking at in the top left is the number of episodes that are there. Then those pie charts in the middle there, you can look at the episodes and cost by site of service. You can look at the specific trigger procedures. In most cases, there are multiple triggers, both a procedure and diagnosis codes that can trigger an episode. So a lot of times it's helpful to see which procedures are triggering, and then you can start to understand if there's a variation in cost by a specific procedure, not just looking at the entire episode. That's the same thing that you see there with the trigger diagnosis. Here, you can track kind of the trends over time, and this is very helpful, especially once you've established the program, to see where changes are occurring, and you can see positive changes, improvements. You can see, kind of worsening in performance, and then, obviously drill down to the individual providers, which is again that table there on the right-hand side of the screen. With the tools that we use, there are a number of ways to kind of build in sort of on-the-fly kind of filters and different ways of visualizing the data that can be very helpful. We use Tableau as a backbone for this kind of reporting, but it is still delivered within our our user interface and our application. We can also educate the team in terms of how those reports are created, and again, a lot of that is still to be determined for your program. I think exactly what that's going to look like, but hopefully this is helpful just to show you the kind of detail here. When you look at the providers, again, they all kind of start with A and have a number associated with them. You see the number of episodes there, you can see the average cost, then you can see the potentially avoidable complications. There's a call out here when you look at the site of service to be able to understand, where are the colonoscopies occurring in the office, in an outpatient hospital, an inpatient setting. These are all different ways of, again, analyzing the data. Sometimes programs will decide to filter out the inpatient colonoscopies. That's kind of a choice that can be made with the episodes. A lot of times those inpatient colonoscopies are more focused on a particular issue, like maybe a GI bleed or, something else that's happening with the patient. It kind of gets outside of the normal sort of, screening diagnostic colonoscopy. So again, these are just all choices, and that we'll definitely work with you to understand what those choices are and help you make decisions so that you can lock it down and then start to track performance over time. This is an example of when you drill into some of those colonoscopy episodes, really understanding how the potentially avoidable complications are laying out, and really looking at kind of the pack rate, the pack cost, the pack rate by provider. And in this case, what you see here is that you've selected a particular provider, and then you can see by diagnosis code, and with the understanding of what is really leading to these potentially avoidable complications, where are they occurring, and what can be helpful is to understand how those providers are performing. You can see here that like the little dotted line in the pack rate. I'm not sure if you can see my cursor. You can see that's the kind of the benchmark or the comparison for for all the providers who have attributed episodes. And then you can see by color, green or red, whether or not this provider's pack rate is within kind of the or under the average or over the average, just by the color and where you see that percentage. Again, that helps you to start to understand where the variation occurs, and then gives you an idea of where to focus, because obviously you don't want to look at packs where the provider is doing very well. You want to let the provider know they're doing well in those packs, because they want to keep doing what they're doing there. But then the opportunity for improvement is obviously the places where the pack rate is higher. This would be an example. The previous provider was doing very well in terms of pack. This provider is not doing well in terms of packs. So you can see that this provider has a lot of red, a lot of measures that are over the average or the benchmark for potentially avoidable complications for colonoscopy. So again, just very sample data, just to kind of give you an idea of the type of analysis that can be done. And then, like I've said, you can drill in not just to look at these individual diagnosis codes, then you might want to look at these episodes. In this case, there were 25 episodes, and it also gives you then the ability to share that data with the providers so that they can see, okay, these are the patients that I was dealing with. This is where, maybe these packs vary by site of service. So this is all the type of information that can be seen. One thing I did also want to mention is, we think transparency obviously is very important in terms of providing specific data like this. But the Prometheus episode content is also available on a website. It is a password protected website, but one that will definitely work with you to get access to that, where you can go in and look at the trigger diagnoses and procedures. Look at all the codes associated with an episode. There's a search function so that you can kind of decide on the type of episode that you're looking for, and then be able to search for it. So that's a good way for providers to get an understanding of what is going to be in an episode kind of before they're measured, in an episode, and for them to understand, kind of the full scope of what they're getting into, with these programs. All right, getting closer to the end here. So this is a maternity care dashboard. And again, I know this isn't one of your kind of main focus, but I think this is helpful in terms of understanding the way that the data can be, carved up and viewed. So what we're looking at here is for, pregnancy, for maternity care, really, kind of how did the cost break down by episode, by trimester, looking at providers who are in contracts versus not in contracts. Again, this is kind of a helpful way to understand not just the performance of providers who you're working with, but also how this compares to those providers in the general community. And the methodology, when we look at our data, we're looking across the full membership. And all the providers who are in that or caring for your population that you provide. So we can identify, if we know who's contracted, obviously what their performance is relative to those who aren't. You can look at measures like C-section rate here. Again, you see in the middle, see kind of an average, C-section rate. And then you can see, kind of over time, if there's any variability there. You can start to look then at individual episode details, look at the average cost, the average prenatal cost, the average delivery cost, and then newborn, if there are some kind of difficulties with associating a newborn with mom, but if there's a way to do that within your program, that is something that can be added in there as well. But again, this is a way that, as I was saying, the episodes are associated to each other. So delivery, whether a C-section or a vaginal birth, are created as separate episodes. And those are actually completed at level 3. Then they're associated to a pregnancy to an overall pregnancy episode at level 5. So it's a way to understand, the total cost of that pregnancy and all the potentially avoidable complications, all the services. But then you can also look just specifically at what's happening with deliveries, and then bring them together in this sort of a view, and then figure out where you want to drill down and do more analysis. And then obviously on the right here, we kind of always get to this specific attributed provider or practice view, looking at their count, their average cost, and here C-section rate is obviously always a concern with maternity care. So that kind of wraps up the reporting view. There were some questions when we went through a preparation for this meeting on talking about custom episodes and kind of how you define a custom episode. This is something that a number of our clients have developed custom episodes. I would say that most of the time custom episodes come up because there's maybe a practice or a provider who's got a very strong interest in being involved in value-based care programs, and maybe that particular episode is not part of the methodology. But it also occurs sometimes when the provider maybe wants to do a more focused view of an episode, or maybe a narrower episode definition. There are really a kind of a number of cases. The vast majority of our clients just use the standard methodology, and then use the configuration within the methodology. One of the things that I didn't talk about, again, there's a lot of detail to get to, but with all the episodes, there are subtypes. Those subtypes are used for risk adjustment, but they can also be used to kind of customize or narrow an episode. An example would be like a joint replacement episode. You might decide that you don't want to include revisions, so joint replacements that are revisions of previous joint replacements, because those can be different in terms of the cost and complications related to those episodes. So by using subtypes, the base methodology includes all those episodes, but you can start to kind of identify particular services within those episodes by those subtypes. It's a way to kind of avoid customizing and still use the methodology. But certainly if there's an interest and a need to customize, then we do have we actually have an engine for that. And we've definitely done that with a number of our payer clients. When we look at custom episodes, we always start off with some kind of basic questions. Really, what is the purpose of this episode? Are we really looking at controlling complications? We look at controlling costs. What are the clinical kind of settings that we're looking at? Are we looking at focusing this in a particular clinical setting? Really, understanding where are those unwarranted variations in the episode, and who's responsible for coordinating care. When we look at episodes of care and value-based care, coordination of care is really the key to understanding who is actually going to be able to succeed. You know, if we just pay differently for services, or we just kind of do this analysis, we don't change anything. Obviously, we're not going to get any benefit out of it. This is one of those models that really requires that somebody understands that they're responsible for this episode, and they take the necessary steps and change their practice, their care, to coordinate care and make sure that, you know, when a patient goes from the hospital to home or hospital to skilled nursing, that, you know, they really understand why the patient is going there, and that they're controlling, for instance, you know, skilled nursing facility costs very greatly. And really, when you look over time, there's not a great correlation in the severity of illness of the patient and the length of stay that they, you know, that they are in a lot of those skilled nursing facilities. So what we've seen is that's a huge opportunity for cost improvement. What we've also seen is that patients, when they are discharged to home and have, you know, appropriate home health care and home, you know, physical therapy, they actually do better at home. They get more mobile, they're more independent, and, you know, especially after procedures like joint replacements or CABG, you know, they just tend to do better, and their outcomes are better. So just making sure that whoever's responsible, whether it's the surgeon or the hospital, whoever's taking ownership of these episodes, kind of understands that, and that they see those opportunities for improvement and then implement those. So these are just the types of questions that we need to answer with you. And like I said, we've kind of got a process that we've put together to go through that. This is kind of a very high level kind of overview of how we do that. Once we've answered those questions, then usually what we'll do is get to kind of the episode definition. So we usually want to understand what are the trigger codes, and that's kind of the initial seed, if you will, for an episode. We want to understand the typical episode duration, and then, you know, kind of understand any other flags that might be custom to this particular episode, like site of service, or, you know, it could be just about anything. Then we start to kind of take that data and do an initial analysis of, you know, actual member data with you and claims data. And then we start to see, okay, what do these episodes look like? And we can usually go through that process for a couple iterations. That usually helps to identify those business rules. So when should an episode be created? How should episodes be filtered? Which providers should be attributed? It is a fair amount of work, you know, to do this, as you can imagine, because you want to get to an accurate episode definition, but you also want to get to one that is practical, and that, you know, is really can be used for measurement, you know, performance, for contracting, if that's where this is going to go. But basically, it's just a process where we go through and look at how the content that has been identified up front really translates into, you know, real world claims and analysis. And then, like I said, there's usually a couple iterations, and we can usually get to a pretty good definition then, you know, we start to share with provider partners, get their input, and finally you wind up with a you know, an episode that can be contracted and used for performance measurement. All right, so that's really the end of you know, my prepared comments. There's a lot more detail that we can get into on Prometheus, and, you know, what I found is it's typically helpful to kind of take this in stages, where you kind of first get an overview, and then, you know, when we get into more of the details and we have more of your data available, that's when we can get into kind of the next level of education and understanding how specific services are there. It usually makes a lot more sense when you're looking at real data and you know, real claims. You know, start talking about the types of reports and everything that can be created. But, you know, hopefully this was helpful, and I'm glad to take any questions at this point.
So Dr. Gonzalez, why don't we start? I'm going to go ahead and go through the questions that were in the chat. Some were answered, but I want to just see if you want to comment on any of them.
Okay.
Dr. Trumbull said, is this limited to Medicare only or all payer? And Madeline from the HSCRC said the program will be Medicare only. However, Care First has an aligned episodes of care program. And then Dr. Trumbull followed up talking about the idea of other Maryland payers being able to use Prometheus as well. Did you want to comment on that? Because I do think one of the things we've heard as we've done this is that we really would like to have as much alignment as possible. So the physician is using kind of one set of game plan or thought process when they're practicing, and not switching from one program to another as they switch from an Aetna patient to a United patient to a Care First patient to a Medicare patient. Did you want to comment on that?
Sure. Yeah. It really gets, like you said, we are working with Care First. They are a client of ours. I think it's okay to say here. So in that regard, absolutely. And we find the same thing. We think that's one of the benefits of a standard methodology like Prometheus is to create that consistency so that it is easier for providers. They're not having to use so many different rules. We are certainly working with a couple of other national plans that have programs in Maryland. But in terms of working specifically with a plan, we're clearly, that's our business. So we are open to working with any plan, but we do need data rights, right? So we need to have those agreements in place to be able to actually do that work. The methodology is out there, it's understandable. We work with partners, so vendor partners who, license the Prometheus methodology, and, we're continuing to make that available. That's been the model, since HCI3 started this, and we continue to, or we are committed to continuing that. Hopefully that helps. It's one of those things where, we obviously can't force a payer to use this methodology, but we can certainly make it available to them. And, if there's an interest on the part of some of those other payers, we're definitely interested in doing that, and we'll do that if possible.
All right, and I would just
Tequila, Jean,
people.
I would like to just maybe add a little bit more on that. Dr. Trumbull, we agree. We think that there is a tremendous opportunity for all payer alignment, though our program is obviously Medicare focused. That is one of the reasons we decided to go with this approach using Prometheus, is because we too believe that it's going to be a lot easier for physicians if there's sort of a common platform that exists across payers. And so we were deliberate to sort of reach out to Care First, and we are doing sort of this demonstration approach to show that the more alignment there is, the better it is for physicians. And then we are certainly open to also engaging in similar discussions with other payers. And so I think you hit it right on the head in terms of the opportunity. We see that as well. And so just as a state agency, we have been open to discussions with other payers and really starting to encourage, sort of a unified statewide platform wherever it makes sense. Obviously, there are differences among payers, and we understand that and respect it. But to the extent, there is the opportunity to align, that creates a better approach statewide. And so we echo your comments and really just kudos to you for such a great observation.
Thanks, Tequila. I appreciate the fact that you guys are looking into that. That's something I've been hearing more and more from physicians as we get into these many programs, because obviously other payers come in with their own interests and things that they're looking at, and trying to, as Jean mentioned, jump from, is this patient have Care First? Does this one have Aetna? Is this one Medicare? And what do I have to pay attention to here? Because, we're also keeping, leaning on them, so to speak, to pay attention to these issues as we enter into these various programs. So that's good to hear. Thank you.
Yep, absolutely.
Right. The next question in chat, and again, if anybody wants to ask a question orally, just raise your hand and we'll call on you. The next question was from Ann Hubbard, and she said, how are you measuring improved patient outcomes? Are there quality measures? And Madeline did respond correctly from the HSCRC perspective that there will be quality measures aligned with CMS MIPS for each episode. We intend to discuss the selections with this group. The final incentive payments will also be adjusted for quality performance. Dr. Gonzalez, did you want to comment further on that?
Right. So the main, I guess, built-in methodology for Prometheus is really looking at those potentially avoidable complications as a quality metric. But, all of our clients also obviously have HEDIS and other, that kind of their base quality measures that can be applied here. And a lot of times we can take some of those quality measures that might require some clinical data that's not necessarily available, 100% in claims, to be used as gates or additional metrics. Some of those reports that I showed, we have reports where we pulled in, HEDIS measures for different, different views and even patient satisfaction sorts of scores. So the methodology itself is very focused, like I said, on those potentially avoidable complications. But if there are other quality metrics that, you're gathering for your providers that, you want to merge in here, that can absolutely be done.
So while we're waiting to see if anyone else has questions, I had one. You mentioned that hopefully we'll have access to this soon. We have various physician groups that we've been working with. We've been meeting with a large ER group that has a program they're trying to figure out. I know there's a urology group that's interested in just seeing how they could fit in. When do you think we'll have access? How do you see that working out time frame wise to some of these physicians who are interested in seeing if they can take advantage of this program can do so?
Yeah, so I'd probably want to defer that question to Tequila and
Yeah.
the project team.
So I'll start, and Maddie, you jump in. So just in general, the way that we are approaching the partnership with Prometheus and Change Healthcare is that, they showed you some really cool designs of reporting options. And so we will be designing sort of a standard suite of reports that will apply to will be available to any of the participating EQIP providers. And that those reports would ideally then be available on CRISP. And so the approach that we're using is we're taking sort of the expertise and the design that Change has created and making it available, again, to your earlier question, Dr. Trumbull, a system that providers are already comfortable with, so they're not having to, relearn some new tools. So that's sort of conceptually the piece. And then we also envision that, there will still be the role that, conveners can play to work with physicians where those relationships make sense. If they want additional expertise and consulting services, that can still happen. But from a standardized reporting perspective, the HSCRC will create the suite. It will then ultimately get displayed or made available to participating physicians in CRISP. And so Maddie, jump in if I've missed anything or anything else you'd add.
I think with regards to reporting, that's been our plan. And we do hope to discuss the designs of those reports, based off of all of the capabilities that the Prometheus suite has in terms of data output with this group as well. So that way we're really pulling in what we think are the most important insights. And then it also is connected through with CRISP data and the regular CRS reporting there. I'll also add in terms of, Jean, I think you mentioned bringing new episodes online and kind of what the timeline is from there. I think from the state's perspective, we want to get a program up and running under our care redesign kind of umbrella for 1/1/2022. And for that start date, we don't want to really rock the boat much. We would like to use the Prometheus episodes that align with Care First, but then also have really been tried and tested by the Change Healthcare team and other clients that they have. In the second performance year of EQIP, we do hope to bring on some new suites or some new episodes. Given that we are still kind of building out that first year, it's a little bit of an unknown of how quickly or how much bandwidth that will take between us and the Change Healthcare team and different stakeholder input that we'll need to get for those. But we are committed in year 2 to kind of thinking about some more customization for, to your point, physicians who have been engaged with this subgroup all along and do represent great opportunity in the state in terms of engagement with our system. So that's the plan so far, but we're happy to discuss further offline if people are interested.
Yeah, I do think though there is a value in getting specialists in to look at that and see what's in Prometheus and see what level of interest we have, so we can put resources towards specialties who want to participate, and that way we can get a high level of participation. So that's great. Sounds like a reasonable.
Absolutely.
Yep. And so, Jean, I think one of the things we were thinking about is that, as we think about how to leverage, this wonderful EQIP subgroup, there's going to be two key areas where we'll continue to ask for input. Certainly one is going to be on the reporting as we, start to design the reports and make sure that they make sense in the context of what physicians, specialists are going to need to take a look at. So that'll be one topic we'll want to revisit with this group in the coming months. And then secondly, as we start to think about, again, those broader episodes, those additional episodes, tapping into this group and the expertise that exists here. So we'll continue to use this group as our sounding board and, wanting to make sure that you all are part of the process to help us design EQIP in a way that really maximizes, participation and works to, sort of align with that all payer strategy we just talked about, and really in the context of how you, care for patients. So I think there's a lot of great opportunity to continue this engagement with this group.
Any other questions? If someone is Zoom challenged and doesn't know how to raise their hand, they can just speak up now.
Hey, Gene, it's Jim again. Quick question. So one thing I haven't heard is the intake of information from the system and from the providers for this program. Is it going to be essentially the same as it is for the other care redesign programs, coming from claims, going through that filtering process, and ultimately through CRISP? Where does Prometheus step in and do their analysis? And then how is that provided back to CRISP then?
Sure. So I can take that.
Oh,
I think you're breaking up, Maddie.
In terms of
You're frozen, Maddie, if you can hear us.
oh,
how's this? I think you guys are again.
Okay, try again, Maddie.
there you go.
Yeah, so in terms of the normal CRP operations, we think, our intake of information for this program will be a little bit different. We do need to streamline it and support individual care partners for kind of that intake and sign up process. So we are working with CRISP as we speak to kind of build out a system that allows providers to be engaged throughout the entire process and understand, what inputs are necessary for CMS, but then also where they'll receive their incentive payments and, get to see their performance. So we're hoping to have a bit more of a streamlined process than normal CRP to really support the independent care partners at the care partner level. So we'll outline that as well with this group as we move along.
Okay, guys, we're 20 minutes over, but we hope and trust that you feel like this has been a productive hour for you guys. At Change, we're really excited about this project, and we have a couple of project launch meetings scheduled over the next couple of weeks. We're going to roll up our sleeves and really get down into the details of the project. But we appreciate your time. Matt, you want to close us out?
Sure. If we can just go to the next slide, I think we'll close it. There we go. So I think we've shown you guys some initial episode lists. We went through the Prometheus suite and pulled out all of the episodes that we felt were both acute and procedural, since those were kind of what we had been looking at, but we want to ensure that we have enough participation available to providers to really drive scale for the practice transformation that we think EQIP is really intending to drive. So this is the initial subset that we've pulled out. They are all voluntary episodes, so you can, pick 1 or 5 or all of them as a provider. And we'll definitely outline, different implications for that in the future. But this is the subset. If there's comment or feedback or questions, we're happy to work with providers and answer those. Some of those we'll probably have to relay back to the change team and kind of go through that process. But at the outset, I think this is what we would like to include for performance year 1.
Any questions or comments on that?
And we realize it's a bit of a big announcement at the end of the meeting, so please feel free to send us comment via email or set up some time to chat if you have questions.
Well, I guess the other thing too, Madeline, if there's anybody who is set on some Prometheus code that does exist, they need to tell us like yesterday. If there was one that they really wanted to do, then that is an existing code, that they need to tell us immediately, correct?
Yes, so for CMS approval, we will have to outline the episodes that we are going to be including in the first year. So we would like to sooner rather than later, Jean. That's a great way to put it.
Yeah, and I'll be a bit more concrete. I would say, we are moving forward expeditiously on the process to, give CMMI information about our intended design to ensure that we adhere to the timeline that we had on that earlier slide. And so I would say in the next week or two, if you all have anything that you've seen that you know about, please reach out to a member of our team so that we can, in fact, have some discussion with you about that. So by the end of the month, if at all possible.
I have a clarification question.
Sure.
And this may have been discussed previously, and this is my first call, but there's a lot of overlap here with diagnoses that fall into the ECIP program. So if a hospital is doing ECIP with care partners who then enroll in EQIP, how does that work with that overlap?
Well, I guess one of the points though that makes it a difference, and I'll let the HSCRC answer the technical question, is that with ECIP, you're only going to be able to deal with the folks that are attributed to you. With this, it's going to be a broader group, so you're going to catch more people. That's the benefit of it. That, right now, and you could work with people who aren't necessarily your physicians, or anybody could do it. So I think that's the big difference.
Right.
I'll let HSCRC talk about what that would mean if you're in ECIP and you're in this down the road, and how would you deal with that issue? Because that's a good question, Cindy.
Sure. So, and I'll also see if Will is on, since he's a little bit closer to the other episode programs that we offer at the HSCRC. But in general, we are going to have a hierarchy of episodes to make sure that program overlaps. We aren't double counting or under counting for some providers. So okay. I think, given that EQIP is at the physician level, so really the strongest locus of control, the episodes will first be attributed to EQIP. And then move on to the other programs as they fall into those attributions. So that's our general plan, though. Will, I don't know if you want to add any other kind of background and commentary there.
No, nothing to add. I think our intention is to go down as close as we can get to the patient, and the doctors are a little bit closer than the hospital and institution, so we'll prioritize them first.
And I'm assuming,
I mean, that helps.
We would also have this issue with some of the CTIs probably too.
Yeah, so we do intend to handle CTI slightly differently, but just because of the breadth of that program. But I think in general, we will align it as closely as we can with that policy that we made there. So if you think about the CTI, any of the episode-based programs will have a similar hierarchy. I think that, we have some palliative care, primary care, geographic care CTIs. So there's a little bit more complexity with that program. Mm-hmm. I think as a matter of policy, it's our intention, when triggering episodes, to trigger as close as we can get to the patient, which means with the doctors before the hospital.
Okay.
So I think the most important thing there, and I think everybody agrees on this, is just making sure that everybody knows the rules ahead of time and it's clear. And I think if that's the case, then it just makes life easy for everybody, or easier at least. Not just for the people participating, but also for you guys as staff, because I'm sure there's nothing worse than having people call and yell and scream about where this should be assigned.
Yeah.
All right, any other questions? Tequila, did we actually get done early?
I think we did.
Oh,
yeah,
my goodness.
I was looking at the clock. I was like, we're not going to 11.
This is great.
Yeah,
So we have some bound time. Well, Jean, I just want to thank you again on behalf of the HSCRC for convening this group and taking the lead. It's again a pleasure and an honor to work with all of you, and we're really, really excited about this opportunity with EQIP. So we look forward to, in a future meeting, sharing more information. Feel free to reach out. I think on, again, one of the earlier slides, you have our contact information. So if there are any questions you have following today's meeting, or again, if you start looking through those episodes and you have questions, reach out to us. We'd be happy to have more conversation. And with that being said, I want to give you all some time back in your day.
And I'll have the
Thanks,
recording up.
everybody.
I'll have the recording up by early next week. So if any of your colleagues want to see this or missed it, they'll be able to watch the recording of it. And thank you to all the HSCRC staff who do a great job doing all the work, and really appreciate the two Wills, Maddie, Terry, Tequila, and everybody else. It's really appreciated. Thanks, guys.
Yeah, indeed. Thank you.
Thank you.
Thanks, everyone.
Thank you all.